hearing from Walt Johnson, the head of emergency and essential surgical care from the WHO, Professor Adrian Gelb, secretary of WFSA, Dr. Lubna Samar, pediatric surgeon at Indus Health Network, G4 Alliance in Pakistan, Daniel Berman, the lead for the global health team at the Challenge Prize Center at Nesta, all of whom have announcements to make today, and we look forward to it. My job is to try to set the stage a little bit about where work in surgery and anesthesia even come into play in public health. It hasn't been an area that people have associated as being central to the work of public health and universal health coverage, and it's important for us to understand why that is beginning to change. The public health and universal health coverage are based on a core principle that all lives are of equal worth. To say that is to say that we are all equally deserving of the capabilities that have been discovered during the last century that have doubled our lifespans, capabilities that have doubled our lifespans if we have a regular source of care for the vast majority of our medical needs, if we're able to afford needed medications and treatments for both prevention and sickness, and those medicines and treatments are given safely. What we all deserve, however, but don't have when we lay that out, is access to a few basic systems of care: primary health care, labor and delivery, pharmacy and diagnostics, and, we're here to say, safe surgery and anesthesia. Surgery, you have to understand, is not a luxury. It is an indispensable part of living a long and healthy life. Few will ever escape the need in your lifetime. Most of us have need for multiple surgeries in the course of our lifetime, whether in emergency child delivery, where a C-section might be needed, in trauma, where a trauma repair may be required. You may need an abdominal operation for anything from an appendicitis to a colon cancer, a hernia operation that would otherwise leave you unable to address a major disability, a cataract to prevent blindness. I got to be part of, a couple years ago now, the World Bank and Gates Foundation's project, the DCP3, the Disease Control Priorities volumes, which examined all of the public health interventions that have been available and tested, and has done it now 3 successive decades. And when that came out, it addressed and found that investment in the first level hospital capacity to provide 44 essential and emergency surgical procedures turned out to be as cost-effective and as necessary as childhood vaccination. The Lancet Commission around that time also helped put some quantification on the gap that there is 5 billion people without access to safe and affordable surgical care. That gap is 143 million people per year without procedures that would have saved their lives or prevented major disability. And even among those who get access to surgery, 33 million a year experience a catastrophic expenditure, meaning that it costs them more than 40% of their entire income to address their health need. Now, all of this can seem impossible. How can we begin to address and provide for this capacity? But I have seen it happen in my lifetime in 2 instances, and it gives us a roadmap of how this begins to change. One place is in rural Ohio, where I grew up, in the poorest county in Ohio, in Athens County. And when my family arrived there in the early 1970s, my mother is the second pediatrician in town, and my father is one of 2 general surgeons in the county. They were the first surgical capacity arriving. My father was doing surgery without access to fully trained anesthesiologists. We had nurses providing, still at that point, ether anesthesia in rural Ohio. So how did that come about? It was directly because of the creation of Medicaid, a program for the poor to have access to insurance coverage for their medical needs. And in a county where a third of the community ended up on Medicaid, suddenly the need was there and the access to the resources that built the capacity. My father is from a village in India, and 10 years ago, that village in rural Maharashtra had the same kind of access developed with the RSBY program, a insurance program for people who were below the poverty line. And with their BPL card, they could get access to 40 essential and emergency surgical capacity needs. And with that, the first anesthesiologist came to his home community, an area that has about 250 villages, almost 1 million people. His name is Shrikant Jaiswal, and he and his wife, an obstetrician gynecologist, became the first surgical capacity in that community, and since then have brought another OBGYN and an orthopedic surgeon. And in the local district hospital then with RSBY, they went from 8 surgeons only available in the general hospital and just 2 or 3 anesthetists to 120 surgeons and a ample supply of anesthetists. When there is funding, then there is capacity. And that's why this is part of universal health coverage. When the US did it, they were at over $20,000 GDP per capita. When India did it, it was at $1,500 GDP per capita. Korea in 1977 instituted universal health coverage, South Korea, in a year where they were just $4,000 GDP per capita. And so we have been learning how to make it possible at lower and lower levels of income and reach enormous good. Now the pattern is that the capacity growth outpaces the quality growth. And so we see that while surgery in the high income settings can be at 1% mortality, we're measuring 3 to 20% mortality in surgery in middle income settings and not adequate measures of it in the low income settings. But we know enough to know that we have upwards of 9 million who are left dead or disabled each year due to complications of surgical care, reflecting gaps in surgery that are present in every country. And that is also solvable. We're now celebrating this week the 10th anniversary of the WHO Safe Surgery Checklist, a straightforward approach that was led by the WHO that created a kind of like a cockpit checklist, but for the operating room, for teams to communicate, to confirm that the big killers that can occur have been addressed and that communication about the specific needs of the patient has occurred in a less than 2-minute team checklist for the nurse, the surgeon, anesthetist, and others that are in the room. The result was in 8 cities around the world, ranging from rural Tanzania to Seattle, Washington, from Delhi to London, every hospital had a reduction in complications. The average reduction was 35%. The mortality reduction was 47%. Programs like Lifebox, founded by organizations including the World Federation of Societies of Anesthesia, which is here today, Harvard, and other organizations, ended up being able to bring that checklist to life in the low-income world, ensuring that basic monitoring with pulse oximeters were available in now more than 18,000 operating rooms around the world. They've fully outfitted more than 90% of the operating rooms in more than 25 countries where they weren't universal, and trained 6,000 anesthetists and anesthesia providers in those skills. The result is we're now past 100 million of the world's 300 million operations worldwide are done with this basic safety procedures, and we're seeing population scale changes, whether it's Scotland and France that have demonstrated 20 to 30% reductions in mortality, state of South Carolina seeing 22% reduction in mortality, or results that are similar to those in Moldova, Uganda, and elsewhere. Now, the structure that's emerging is that With these building blocks in place, the next movement has been to create what's called NSOPs, National Surgical Obstetric Anesthesia Plans at the country level, where each country defines how they intend to make this system and set of systems work. Usually, countries in public health have been making disease-based plans. What are we going to do in HIV? What are we going to do in TB? But instead, the recognition this year that I think is the breakthrough is that we need national plans around our systems themselves. A national plan around primary health care and a national plan around surgery, obstetrics, and anesthesia care that care for the majority of the medical needs across people's lifespan. So here today, we have a series of people who are discussing the next major breakthroughs in being able to advance these core ideas, with an announcement of guidelines from WHO and WFSA about standardizing safe anesthesia that represents the next major leap forward after our checklist work, perspectives on surgical practice in Pakistan, and then an exciting prize that represents another major leap forward in funding to be able to make this work happen from Nesta with its Surgical Equity Prize. So with that, let me turn now to Walt Johnson, Head of Emergency and Essential Surgical Care at the WHO, and Professor Adrian Gelb, the Secretary of the World Federation of Societies of Anesthesia. Gentlemen.
Can we stand at the podium?
Would you like to stand at the podium? Sure.
Well, I can see myself. Good morning. It's really a privilege to be here, and I'm a neurosurgeon by background, but I still represent the surgical community, I think. Many of these slides, most of you have already seen before, but I wanted to eventually talk about some of the things WHO is doing to scale up surgery and anesthesia around the world, and especially our goal of universal health coverage. Is there any possibility of seeing the slides up here? Okay, that'll work. Thanks. Okay.
Which one is it?
Safe surgery. There we go.
Just press the
All right.
here.
Great. After 50, your memory's shot, so I need slides, is my mnemonic. Anyway, as you know, the surgery program at WHO started with Afton Mahler, and he really couched surgical care as a social justice issue. And we're talking, especially as Atul mentioned, equity. Every life matters. And if you take surgery out of that equation, there's estimated 17 million lives a year lost because surgeons aren't available. We're continuing this tradition. Afton Mahler made this speech in 1980, 38 years ago. You've all seen this slide, 5 billion people that lack access to surgical care. The other thing is that we don't have any money for it. As Atul mentioned, there's no funding, and access to care is predicated on funding available for people's needs. This is a slide I've shown many times. You've all seen it. But HIV, TB, and malaria have a global fund of $5 billion per year for 3 million deaths. I'm not minimizing those deaths, but there's 17 million with lack of access to surgical care. We need to change that. You've all seen this slide before. NCDs are going through the roof in even the poorest countries. Communicable diseases are going down, and surgical care demand goes up in parallel with the NCDs. So 5 billion people, no funding, and it's getting worse. because NCDs are really climbing through the roof. You know about our resolution decision point that was passed a year ago. If you're not aware of it, our resolution only called for one report, which was last year. Decision makes reporting on surgical care and surgical indicators part of the Sustainable Development Goal reporting, which is every 2 years from now till 2030. It keeps surgical care on everybody's radar. We can ask member states, what have you done for surgical care? You voted for the resolution. We can do that every 2 years till 2030. So you know the parts of the resolution well. What hasn't been done of the resolution is the one at the bottom, where they promised $23 million over 5 years for 7 people, 1 here in headquarters and 1 in each of the regional offices. That $23 million was just something to put on paper. And basically, I got a pat on the back saying, you need $23 million, buddy. Good luck. We need that money. I'm going to let Adrian announce these safe anesthesia guidelines, but we're very proud of them. And one of the things I especially want to do is a number of guidelines. We're working on Ebola guidelines for surgical teams. We're working on several guidelines presently that will just set the standard. This is what you need to do in your country to provide surgical care at whatever we're speaking about. The other thing I'm trying to do is develop collaborative centers. When I started here 3 years ago, we had 1 collaborative center. Now we have 5, and working on 3 others, and 2 on top of that are kind of in the infant stage or fetal stage, if you will. Just discussions about how can we develop it and make it further. And you think, well, this is great. We have 5 collaborative centers, each with a specific niche that they fill, looking at one particular part of surgical care or anesthesia, and that's fantastic. But if you look at maternal and child care, they have 43. If you look at reproductive health research, they have 34. So combined between the two, 77 collaborative centers. So 5 is really a drop in the bucket. Violence and injury protection is, they have 21 around the world. So we have a bit of ways to go, and I think there's plenty of room for collaborative centers on specific topics in specific parts of the world. And then the WHO wants us all to link these collaborative centers as a network or a community of collaborative centers that work together and synergize, and hopefully the sum of the parts is greater than the parts themselves. National Surgical Obstetric and Anesthesia Plan was first discussed as part of the Lancet Commission. This is from the Lancet Commission itself. And everyone said, well, what a great idea. And Zambia, who was one of the first countries that 1 year ago handed out their published and costed National Surgery Obstetric and Anesthesia Plan that was from 2017 to 2021. That was handed out at an official side event that we had at the Palais last year. At the end of that session, John and I were bombarded with countries that wanted help with national surgical plans. There were so many countries that all of us combined couldn't go country to country and develop national surgical plans. So John and I decided, well, let's just have a workshop and invite people to come to the workshop, and we'll lay out the nuts and bolts of how you do this. The advantage of that is that it's owned by the country. We're not giving them a national surgical plan that they can put on the shelf and ignore, but they actually have ownership, and it's much more likely to be sustainable. So we had our first national surgical planning workshop in Dubai in March. We thought we'd have maybe a dozen countries show up. 21 countries came. We had to turn countries away. And these countries are enthusiastic, they're committed, they're engaged to this process. And all we're doing is kind of helping them with some technical details. We're creating a manual on how to do it. We've already been asked to do a Francophone version for West Africa, Southeast Asia, and then a Spanish version for Central and Southern America. And then again, we want to form this community of NSOAP countries that can get together and talk about success stories and challenges and things that they have overcome. The big issue with national surgical plans is implementation. As you know, corporate America has all sorts of strategic plans that are on the shelf that have never been executed. And we're not troubled, but it's in the back of our minds that we don't want national surgical, obstetric, and anesthesia plans all on the shelf in many countries around the world that haven't been implemented. So the big thing right now is implementation. How will we do it? And we want to make sure that it succeeds. We just had a fistula meeting at WHO, bringing in gender health and other people. We're connecting with the maternal and child health groups, and really their groups have been involved, the WHO groups have been involved with maternal care, but the surgical piece has been sadly lacking. So they're really happy to be working with us to develop surgical care in maternal health. Another thing we're working on with Lubna is pediatric surgery. This slide just shows on average in sub-Saharan Africa, 43% of the population is below the age of 15. And many countries, Niger, the population under 15 is about 50%. Adult surgeons are reluctant to operate on these kids because, first of all, they're too small, the risks are greater. The pathologies are different than what adults have, and kids don't have any money. Doctors like to get paid. And so it's a very vulnerable population. So we're working with the Children's Health Group at WHO, as well as with the Global Initiative for Children's Surgery, working on optimal resource documents. What do you need to have children's surgery safely at district hospital level, secondary hospital, tertiary, and hopefully a national children's hospital or a regional children's hospital that will adequately give any type of service to kids that they need. Lastly, we're trying to be a little innovative. In Australia and in Canada, they have family medicine doctors that are called proceduralists, and they go to remote parts of Canada and Australia, and their training includes an extra year of obstetrics or surgery, so they can do just essential surgery and obstetrics way out in the boondocks where they may not have access to getting patients safely or in time to a higher level of care. So I've been discussing this with the family medicine group, and I have no idea how the World Federation of Family Medicine becomes WONCA, but WONCA is the name of World Federation of Family Medicine. It doesn't work in any language. I have no idea where it came from. But Key Park and I have been accepted for a seminar on the integration of family medicine and surgical care as part of the training. In sub-Saharan Africa, family medicine training is not looked at as a cool thing to do. And every country in Africa has a surplus of medical students that graduate from medical school, way more than they have training spots available. Additionally, in sub-Saharan Africa, students pay to get trained in surgery. It's on average about $5,000 a year, but they have to pay the university or training program for that privilege of being trained. So we're working with WONCA on building more training facilities, and I mean, can you imagine if we had family medicine docs that had extra training in essential surgery and obstetrics in every district hospital in sub-Saharan Africa? It has a bit more appeal than taking non-medical people off the streets, teaching them how to do C-sections. Excuse me. Lastly, thanks. I'm just overwhelmed with this. Lastly, our new Director General, Dr. Tedros, has outlined global program of work, which surgery has a tiny sentence in there. We're working on getting a paragraph, but everybody is trying to get their paragraphs into the global program of work. But he has the 3x5 initiative, which is 3 billion, the triple billion goals within 5 years. 1 billion more people benefiting from universal health coverage, protected from health emergencies, and enjoying better health. Surgery and anesthesia and obstetrics have to be an integral component of all of these 3 goals. And I think with Dr. Tedros, he's very supportive of surgical care, obstetrics, and anesthesia. I think we'll see great strides over the next 5 years. Thank you very much.
I assume it's on that stick, otherwise I have my own.
No, it was already for early comers. It's here. This is not.
No, the green one.
This one is
yours. Okay. I'm Adrian Gelb. Thank you very much for joining us this morning for this important discussion. My name, who I am, and the World Federation of Societies of Anesthesiologists information is up there. My email is available to you. Happy to get emails from anyone with suggestions, recommendations, compliments preferred, but I'm happy to take criticisms as well. And my Twitter handle is there. Let's tweet the hell out of this morning's session. The World Federation of Societies of Anesthesiologists began in 1955 as a fairly small organization bringing together national anesthesiology societies. We've now grown to over 135 national societies representing 150 countries. That's in excess of 200,000 physician anesthesiologists around the globe. So a large network. I am emphasizing somewhat the anesthesiologists because we do have a soft campaign running to create a global identity for physician providers of anesthesia to be anesthesiologists. Because one of the things we need is a standardized nomenclature as we go forward. Anesthesiologists is what we prefer. And actually, the Irish are currently voting on changing from anesthetists to anesthesiologists. So we're holding thumbs. Our vision is quite consistent with what everybody has said so far: universal access to safe anesthesia, and we unite anesthesiologists around the world and other anesthesia providers with that intent. And we work not only with our own but with surgeons, other organizations, WHO, governments, non-governmental agencies to achieve that end. What are some of the things we are doing? 3 guiding pillars for the WFSA's activity: scaling up the workforce, universal health coverage and access, and safe anesthesia for all. In terms of workforce, one of our important projects and ongoing projects was mapping the anesthesia provider workforce. This is at our website, wfsahq.org/workforce. You can hover over any country and you can see the number of physician anesthesiologists, nurse anesthetists, other providers in that country. And if you click on the 0.49 there, you'll get a page that gives you a lot more information about healthcare in the country. And the intent is to keep this as an ongoing, updated database. For those of you who aren't familiar with some standardized definitions, I frequently get asked, so what are standards? And if I don't stick to standards, will I go to jail? Standards are desired and achievable levels of performance against which actual performance can be compared. And they do allow benchmarking across hospitals or regions or countries, and they also allow benchmarking over time. They need to be patient-centered, they need to promote best possible outcome, and they need to minimize exposure to risk of harm. But we need to remember that simply setting standards isn't good enough. The standards really need to be about patient safety. They need to be built on a base of patient safety. Unsafe care is simply uncaring. It has to emphasize safety. And the important aspect of safety is that it's really about trust. It's not just in trust in myself as an anesthesiologist, my surgical colleagues sitting up here when they deal with patients. It's about trust in the hospital system. It's trust in our regional and national governments. And we need to make sure that our hospital administrators and our politicians understand that when they are providing for safe anesthesia and surgery, they are building trust in the community. So I don't see safety as a choice. To quote a football player, Jerry Smith, safety isn't expensive, it's priceless. So let me introduce you to the WHO WFSA international standards for a safe practice of anesthesia, because we felt the place to start with standards is to set the standard for safety and then build practice on top of that. This was EPUB'd about 10 days ago. It's freely available at the WFSA website, or if you do a PubMed search on my name, it will come up with a choice of journals, because it is co-published in a number of journals. This was just a phenomenal collaboration between ourselves, Walt, others at WHO, and a global workforce team representing a variety of constituents, not just physician anesthesia providers. The importance of having international standards as opposed to local or national standards is that it establishes a uniform international expectation and standard of what care should look like. So it shouldn't matter whether you're going to your local hospital, national hospital, or you land up in a hospital in a foreign country. You should expect the same level of care. All patients should expect the highest, safest level of care, no matter how simple the healthcare facility is that they go to. There should be one standard, independent of provider. It doesn't matter whether you're a physician, a nurse, other anesthetic worker, provider. The standard needs to be the same. We understand that these are somewhat aspirational, and an interesting aspect from the workforce is that those of us from high-income countries would say, no, that's too high a standard, not implementable in low-income countries. And the almost instantaneous response from those in low-income countries is, no, we need it there so we can go to our governments and leverage it out of them because they don't believe us. It was just not what I was expecting, this complete reversal of where one should set the bar, and that the bar should be higher than we actually have now. And we'd like to see patients using this as a lobbying tool. Patients are an untapped source of political will around the globe. They're connected, they're influential. We should be getting them engaged. Our opening statement's consistent with Atul's opening statement. Access to safe anesthesia for essential surgery is a basic human right, and it should be available to everybody in the world, irrespective of their ability to pay. No patient should be held ransom for safe anesthesia and surgery. The standards are classified under these headings. I'm not going to take you through them, but to just give you a flavor, they are structured according to a health facility. So if you are a level 1, simple, freestanding clinic, these are the simple expectations. If you're a district hospital, those two together, and if you're a tertiary referral, all three of those. Now, one of the important aspects I emphasize about standards is they allow benchmarking. And so we've taken the standards taken a leaf from Atul's workbook, so to speak, and turned it into a checklist, an anesthetic facility assessment tool, so that hospitals, regions, national governments can actually assess whether they are meeting those standards. Use of such tool fits in two aspects of doing an NSOAP, both the initial situational analysis and then the monitoring and evaluation. So it's an iterative process. Fairly easy to do, takes about 40 minutes to do the detailed capacity inventory. Where does one get the AFAT or a copy of the WHO WFSA international standards? Freely available at the WFSA worksite. If you go to the AFAT link, you'll be able to download the assessment tool. It's free. You can download the PDF. We're also offering free of charge secured access to our REDCap account. So we have a number of national governments now that are uploading their data to our website. We're doing some basic analysis for them and then returning the data to them. And we're hopeful that AFAT in some form will be integrated into the WHO Health Facility Assessment Tool. So in conclusion, the international standards, which we have been really excited at the global response from high-income, middle-income, and low-income individuals. Been stunning, the overwhelming email traffic and excitement about it brings us in alignment with an implementation of Resolution 6815, making anesthesia and surgery basic human rights. It's a tool for advocacy. It's a tool for capacity assessment. It's a target for some to aim for. It's a target for all of us to exceed. And the endorsement by WHO, the partnership, puts these standards on the global health agenda and sets, I think, some of the basic standards that are integral to the Nesta Prize in terms of how do we advance safe care. This provides the global substrate for safe anesthesia as an integral part of safe surgery. I hope we'll all work together on promoting safe anesthesia and surgery for every patient, in every country, in every time they need access to care. Thank you very much.
Now I'd like to turn to Dr. Lubna Samar. Apologies for my mispronunciation earlier. Pediatric surgeon, Indus Health Network with the G4 Alliance as well, from Pakistan.
Just get the slides. No, that's not my tool.
Where is it? On this one?
Her name's on it. Yeah. There.
Okay.
Good morning and assalamu alaikum. It is such a pleasure to be talking at an event where the title has two of my favorite words, surgery and equity, in the same. And, you know, prize is a great word too. So, so having all of that together in one slide is absolutely fantastic. I'm representing the G4 Alliance here today, which is a group of implementers, innovators, advocates, and champions that have been working for the past 4 or 5 years to put surgical care on the global development agenda. And obviously, there are so many partners who are working towards that same aim. This is a large group of people from different parts of the world, and currently there are about 90 member organizations, which in turn represent over 300 organizations worldwide, and this includes representations from academia, from professional societies, NGOs, and public and private sector organizations. I am one of the last groups, that is a private sector organization based in Pakistan. G4 really provides a platform for engagement. It works through consensus building through its member organizations and with other partners. And we really work on the strengths of our member organizations to improve practices in surgical care, to mobilize the right resources, get the networking going, and to work on tools. And Adrian mentioned a very important tool earlier that will make implementation feasible on the ground. So really, I've kind of upped this a little bit from Pakistan to a South Asian context. And really, the reason is because this area of South Asia, most of the countries are post-colonial republics that have very, very similar challenges, issues, problems, and hopefully solutions in their systems. So really talking about Pakistan in isolation underrepresents the area that we're talking about. Between India, Pakistan, and Bangladesh, these are large populations. Each one of them has significant disparities within their own countries. There are really pockets of prosperity and excellence in seas of poverty in each of these countries. Large rural populations, large populations living under the poverty line. But looking at it together, this is 1.7 billion people that represent almost a quarter of the world's population. And understanding the dynamic of this area is essential because the ability to impact this population base is very attractive for all of us. So just looking at India, Pakistan, and Bangladesh in terms of numbers, large populations, significant income disparities, very high maternal mortality figures, it's really about the same in all three countries. The populations that are at greatest risk of surgical inequity are rural populations. All countries continue to have significant populations living in villages or small towns with poor access to surgical care. The poverty ratio is high, and the population living in slums, so it's not only a large rural population, but really the slum population in urban centers is often worse off than their rural counterparts. And this is also a significant component of the people that we need to cater to. There is a strong private health sector in addition to a public health sector. The differences are really that the public health sector was planned very well in most of our countries in the post-colonial period to have countrywide coverage. Pakistan, for example, has an excellent tiered health system on paper. There is a tehsil headquarters, a district headquarter hospitals, there are basic health units at the grassroots level, all connecting into urban tertiary care centers. But when it comes to implementing those amazingly well-designed, projects and plans, there are huge inefficiencies, huge disparities. And as a result, we are unable to provide even essential surgical care in the public sector at this time. The secondary level hospitals are the only option for rural population in majority of the cases, but as the subsequent data will show, they aren't able to meet the challenge that they're supposed to. As a result, the private sector has flourished. It's a very well-developed private sector, but it is concentrated in urban areas. A high proportion of the population, almost 70%, depends on this private sector for healthcare. And this obviously puts populations at very high risks of catastrophic and impoverishing health expenditures. So if you were to look at the current health expenditure per capita, I think $45 is the recommended WHO cutoff for basic health, to meet basic health needs. Pakistan and Bangladesh are below that cutoff. The domestic private health expenditure is 69% of the, as I said, around 70% of the health expenses in these countries are being met through the private sector, of which the vast majority is out of pocket. A very small percentage is coming from NGOs, philanthropic organizations, but the bulk is what the person has to take out of the pocket. And more often than not, they don't have that money to take out of the pocket. So there is no health care being given to these people. And therefore, 3/4 of our populations are at risk of catastrophic expenditure, and about the same for impoverishing expenditure specific to surgical care alone. Again, I think going back to where I work at the Indus Health Network, it was started by 3 surgeons and 1 anesthesiologist. That's really a kind of a model demographic for what we're talking about here today. And the reason really was that when somebody has a diabetes, they need to shell out a certain amount of money every month for medicines, for care, for a doctor's visit. And most people can somehow manage that. But a single surgical procedure, be it a hernia or a bypass or surgery for a laparotomy, even a C-section, is catastrophic. And that difference is an important difference to recognize when we focus on the need for surgical care being part of the universal health coverage. There was a health facility assessment done in Pakistan through the Technical Resource Foundation, which is a UK aid funded consultancy. And they looked at an assessment of government health facility. They based their tool on the EMOC checklist. Surgical capacity was partially assessed during this. So this is the closest approximate we have, but this really looked at surgery as C-sections as part of the maternal health package. They looked at surgical workforce, drug supplies, and equipment, and this is about 6 years old now. And they found that there was significant insufficiency of equipment at the district hospital level, as well as drug insufficiencies. So if you look at the 51 to 75%, that's really where the bulk is lying. Out of 108 hospitals surveyed, these are all 108 district hospitals in the country, there were no gynecologists in a third, no anesthetists in almost half, no OR technicians, no blood bank technicians, or anesthesia technicians in a majority of these hospitals. Now, what makes it worse is sometimes you have an anesthetist in one facility and a gynecologist in the other. So this number is actually more depressing than even these figures say. Now, keep this in context. We are a country with more medical colleges than I can count. I was talking to my orthopedics colleagues. The Pakistan Orthopedic Association has 900 qualified orthopedic surgeons on its registry. We have 1,500 orthopedic residents currently enrolled in programs, training programs across the country. We're graduating about 100 qualified orthopedic surgeons a year. But clearly, they are not making it to the district hospital level. So this is another example of, I'm demonstrating really within a country the kind of disparities you face, just because people would much rather live in cities, or even better, move to the United States, the UK, and the Middle East, where job opportunities and pay scales are much better. So we really are exporting a medical workforce to many parts of the world. The barriers we face is age discrimination. The very young and the very elderly do tend to suffer more. The female gender discrimination is a problem, both in terms of the patients that access it, the people that are providing health care, and the policymakers. On this podium today, we have about a 20% representation of the female component of our society. There are alternate health providers. The perceptions regarding disease and potential for treatment is very different. Females prefer female providers, and personal expenses for healthcare are often the problem. I'm running out of time, so I'm going to wind the next 2 slides up very quickly. We already have our ministry's support to start the National Surgical Planning process in Pakistan. We've met with the Secretary Health, the Director General Health, the WR, and we are ready to develop a Vision Surgical Care 2025 for Pakistan. We're starting with hosting a stakeholders meeting in Islamabad. We are in the process of developing a steering committee, and we are starting a national baseline survey, which will look at Lancet indicators 1, 2, 5, and 6. We're looking at 1,200 households, 20 facilities, and 480 patients coming to facilities. John and his team are working closely. The PGSSC's team is working closely with us to get this survey off the ground in July 2018. And we're holding a stakeholders meeting in November 2018 in Islamabad. All of you are welcome to come. And the idea really is to engage stakeholders across the private, public sectors, professional associations, as well as use this as a forum to present our preliminary results from the baseline survey, identify priority areas, and build a consensus. So this is our roadmap, and the conversation has just started. But as we say, a journey of 1,000 miles starts with one step, and we were there. Thank you so much.
Thank you, Dr. Samad. Finally, we'll turn to Daniel Berman, who's the lead for the Global Health Team for the Challenge Prize Center at Nesta. And he'll be presenting on the Surgical Equity Prize and opportunity that it represents.
While we're setting up, I just want to mention that we're new to this community. So we try to be a bit humble, and we really can't say French. Okay. What I was saying is that we're new to this community, and that we really appreciate being part of this and how warmly we've been welcomed. And I think the reason that we have been welcomed is because hopefully together we can address some of the key challenges that we're all facing and that you've all been facing for many years. And one key thing is to actually grow the pot, the resources. So it's not just about a prize, but we hope that that is part of something much larger. Okay. Shannon? So it's not just about a prize, but we hope that that is part of something much larger. So it's not just about a prize. For a prize in surgical equity.
The discovery of antibiotics has been vital for our survival.
So it's not just about
from treating common ailments to complex organ transplant. The discovery of antibiotics has been vital for millions of lives for decades. From treating common ailments to complex organ transplant. The discovery of antibiotics has been vital for treating common ailments to complex organ transplant. The discovery of antibiotics has been vital for our survival. From treating common ailments to complex organ transplant. The discovery of antibiotics has been vital for our survival. From treating common ailments to complex organ transplant. The discovery of antibiotics has been vital for us. From treating common ailments to complex organ transplant. The discovery of antibiotics has been vital for us. From treating common ailments to complex organ transplant. The discovery of antibiotics has been vital for us. From treating common ailments to complex organ transplant. The discovery of antibiotics has been
Prize, which is a £10 million prize to develop a rapid diagnostic test to differentiate between viral and bacterial infection. And that's just one example. So, for example, that's people competing in 20 different countries, and actually is quite advanced. So we're very optimistic. So just in general, what are challenge prizes? So they're challenge or inducement prizes are a method for spurring and supporting innovation. It's a reward to one or more competitors that most effectively meet a defined challenge. And when we talk about solvers, we mean the people around the world that will compete for the prize. And what we find is that this, when you clearly define challenges and you say, we need these products, we don't say what the products should look like, but we say, or services, what they need to do. And what that tends to do is it brings additional people in who wouldn't have been involved in inventing these types of products or services, people who are very focused on data and never really thought about surgery, and all of a sudden they're working on surgery. And in terms of the Surgical Equity Prize, we want to be clear that we know that there are a lot of manufacturers in this space, and that they are bringing innovation and they're committed to bringing it to developing countries. But I just want to put out a question there. If you think already there are enough adapted products, and we've dealt with things like high humidity, dust, inconsistent electricity, there's no reason for a prize. That's just part of it, because that's the product side, but we also talk about services. So we want to bring new products, adapted products, and services. And I'll show you what we mean more specifically. There's also a huge element of advocacy. I think a lot of people in this room have been frustrated because we're doing so much, but we haven't really broken through. And for example, day one in the World Health Assembly, that wasn't part of the universal health care. We want to be part of that. We're humble, but we want to be part of that and change that. So now I just last thing is I want to look, we had this meeting in Milan, we brought together 50 people from around the world, and we started to define some categories that what we call could be prizable. So when we talk about product development, we are talking about things like modifying existing products, creating new products. And just to throw one example of this, I know it's very challenging and it might seem too difficult, but example, blood substitutes. There are a lot of things out there. Are they getting enough attention? Do the people who are working on them have the right collaborators? And are they being funded? So those are the type of things that we want to look at. Enabling task shifting, or task sharing rather. I think here what we're talking about is using modern technology to bring, to basically the revolution that we've seen in education, and we're really seeing it in this space. And so there's two levels on this. One way to enable task sharing is through training and using modern technologies and basically allowing people to get skilled up. But then the other thing is, of course, what was previously called telemedicine. But the next generation of that, what is the role of the expert, and how can we potentially create products that would enable that? And so another thing is when we talk about incentivizing antiseptic practice, behavioral changes are really challenging. But we think a prize, probably the way that we impact this is by potential redesign. So potentially some redesign of operating theater to reduce risks and to build on the standards that have been put out there. Data platforms is, we've been in this area for a few months. We're constantly hearing, you mentioned it, this idea of how do we know what our baseline is? How do we collect data in a way that won't be a burden to the teams, because we know they don't have much time. So those are the type of things. And then business models. financing is obviously really key. Now, you might not think, well, why a pot of money which attracts people around a challenge? Well, maybe it could be a financing model. We talked about the role of the private sector. So how could we mimic some of the things and merge the boundaries? Because that's really what we need to do. How can we, oftentimes we have 70% of the resources going to 30% of the people. So are there some creative financing mechanisms? Before I say who's, you can take a look and see who's on our steering group. These people are helping us. Basically, they're our backstop. So our team at Nesta does this research process, and this is the group that helps steer us and says, yes, we want to go in that direction, or no, you need to look in this. And I think one thing I'd like to be super clear is we're not going to look at all of these areas. We're going to pick one or two, and what we want to do is have a 6-month period of research, and obviously it's already starting, and so a lot of you would be involved in that, and at the end of that process, we have, okay, this is what we recommend with this group validating it, and that we can launch a prize, which would be, so basically this is the last slide. There's basically 2 phases to this project. One is a 6-month period of what we call research and development, so for a prize, and we've started that process, and we've been speaking to funders, but to be honest, we haven't yet secured the funding of that. And then we already start of looking for putting the prize pot. I put 5 million plus because other prizes that we're doing are between a few million to 10 million. We could imagine this one up to 15 million. And the last thing I want to say on this is something that seems a bit strange is the World Bank has clearly made this a priority, right? From their leadership all the way down in the organization, their role in the Lancet commissions. But isn't it time that they convened a meeting about financing? I know we're going to talk about this on Thursday at the meeting that Walt, maybe out of that meeting we can say, okay, there needs to be a small meeting where we bring together foundations, bilateral, multilateral aid. So I'll leave it at that. We really look forward. This is just the beginning. We knew it wasn't going to be easy, but we are fully committed and engaged to making this happen. Thank you.
How are we doing for questions? Do we have time? Okay. Why don't we turn the podium open to questions across any of the domains that you've heard about today? Dave.
I'd like to just ask Lubna about you said you were having David Waters from the Royal Australasian College of Surgeons. I'm interested that you were going to be looking at indicators 1, 2, 5, and 6, and I wondered what your decision making was behind not looking at surgical volume and perioperative mortality rate for Pakistan, because I presume that most hospitals would know how many operations they do, and I would also presume that most hospitals, if you are going to provide safe care, should know whether patients live or die when they leave the hospital.
Dear, thank you. I think it was, we weren't really meaning to exclude 3 and 4. The idea really is to phase this one in first and then put in something for the perioperative mortality as well as the 3 and 4 into a later phase. So again, in no ways not doing that, but phasing that out a little bit. Because obviously this is through a small research grant study, and there are limitations to time as well as funds, and it was a very practical decision. Again, I think the focus was, in this particular survey, we're going to be going out to the communities, and therefore understanding access and tying, because access from when you ask the population from versus when you ask patients who come to a hospital are 2 very different stories. So we're trying to see what, going into a little deeper, there have been a lot of modeling studies on what 2R access is, where a patient is and where the facility is. that does not really mean the patient is using the facility that is, in theory, accessible. So really, the idea was to look at access as a first step, and the facility survey will happen soon.
I'll add a little bit to that just to say we completed a trial in childbirth in North India in UP, Uttar Pradesh, where we were able to get to almost 90% of the patients and their 7-day outcome using a single call center in Lucknow. Now, we had the advantage that there's a program called JSY that gives the family a payment for if they deliver in a facility. And in order to get their payment, they also give over their phone number. And so you can use that system to track down how well the baby did. But a potential prize subject is how to capture at low cost these basic measures of, that allow you to monitor the function of the system.
Of cases we have prepared this year to our project. So 80% cases, it is out after the hysterectomy operation, and 20% cases it is after cesarean section operation. So the hysterectomy operation, we are discussing that how to deal with this situation. So that is also how to define safe hysterectomy, and what is if there is an indicator that how to understand that how our program is progressing on whether we are improving the safety standard of hysterectomy operation in Bangladesh. So that is one thing about the hysterectomy operation. There is another problem about challenge, big challenge I think about cesarean section operation. Last week I was in the West Africa in Ghana, Accra, and we found that in West African countries in rural situation, the access to cesarean section rate is 1%. In some town it is 18%, 20% in West African situation. But in Bangladesh, where roughly half of the deliveries happens in home and half in institutions, the rate of cesarean section from population base is, last reports 31 to 39% from population base. But in institutions, it is 75% overall cesarean section rate, and in the private sector is growing, and now much more people they are going to private clinics for operation, and now in private clinics in Bangladesh 87% cesarean section rate. So if you look at maternal health situation in Bangladesh, last 10 years the maternal mortality it did not decrease. It is perhaps it has increased. It is now 196. Per 100,000 live births. So why the maternal mortality rate is because the economy improved, the girls' education improved, employment improved. Then why maternal mortality did not respond to that thing? So I don't know. Perhaps one of the explanation is the quality of cesarean section and the increased rate of cesarean section. So how to handle this cesarean section thing? So perhaps that is one thing that perhaps if the governance...
Maybe we can take just those two questions and try to answer. If you can hold to those two questions, possible?
Yeah, how to address, how to do more about addressing the equity issues in doing cesarean section.
Yeah.
Perhaps that is one question, and the other thing is hysterectomy operation. How to make it
So. I'll just summarize for the people who are online, since he didn't have a microphone. An excellent set of questions from a gentleman from Bangladesh regarding two major problems. One is iatrogenic fistula rates rising because of hysterectomy. He cited a clinic where they're finding 80% is from hysterectomy and not from obstructed labor and lack of C-section. And then the second is that the C-section rates in facilities rising to the point where on average in private sector it can be 40%, but in many individual facilities it's 75, 80, 85%. So, and how to address that. So I have a couple things to say about that, but open it up to the panel.
As a non-surgeon, perhaps I shouldn't be commenting here, but what strikes me is that the one word we haven't emphasized is the appropriateness of the surgery. So we've emphasized the need for access, easy access, for surgical care that needs to be safe together with the anesthesia. But I think the other component that we do need to emphasize is that it needs to be appropriate and, in my opinion, by international standards. I was in Brazil a couple of weeks ago. They have a cesarean section rate of about 80%. So very similar to Bangladesh. I'm not in a position to comment whether it's just a money maker, but we need to emphasize that the surgical access needs to be for internationally approved indications, so it needs to be appropriate.
If I could just add to that, I think going into the C-section question in its own, it really reflects the dichotomy between public sector and private sector and how the two work together. But just looking at the rate itself, the first question would be what the denominator is. What usually tends to happen is that people who deliver normally or can deliver normally do so closer to home. Smaller centers take care of it. So often the patients that come into the cities, be they private or public sector hospitals, are the ones who have not managed to deliver or have a past history of not delivering in their local setting, and therefore they need to come into town for an operative delivery. And that perhaps might be one of the reasons. I'm not saying it is the reason. And again, I think it's important to understand what the denominator is that is coming to your centers.
I'll just add in that at Ariadne Labs, the center where we do research on health systems innovation for global care, we've recognized that this problem of the very high C-section rates and very low C-section rates is a significant problem. You have a kind of barbell distribution of cesarean section delivery. So we were working in UP, you will see that in our population of patients seen in primary health centers, it's a less than 2% access to C-section, and those who need it are not getting to it in time. The centers where there is C-section provision is often 40 and 50% rates, if not higher. And then when you break down even at those rates, we've been in facilities where we've observed they have C-section capability from 9 to 4 o'clock. The C-section rate is almost 100%. And then in the night, the C-section rate is almost 0%. So it gives an indicator of this being provider-driven rather than need-driven. And when we look across many countries, we see this in the United States, where we've documented, where colleagues have documented that the C-section rate varies from 7% to 70%, depending on what facility you go to. And it's one of the few fields where when you adjust the data for the risk of the mother, as Dr. Neil Shah has pointed out, that the adjustment causes the disparities to increase rather than decrease, a sign of it, how much of it is really provider-driven. Now, that said, there has been no scalable solution demonstrated for improving the appropriateness of cesarean delivery when people come in. It is a ripe opportunity for clearer guidelines which have actionable steps and potentially, yes, even a checklist that could be employed to provide more guidance. It's a complicated set of decisions that we're now testing out solutions that, and we have a ways to go. And so, again, on the list for Nesta Prize would be being able to address appropriateness in surgery, and C-section is the classic case of inappropriateness in care. I wonder if I can put Dr. Laura Franzi on the spot regarding the first question. She's probably the person in the room who has the most experience dealing with iatrogenic fistula in a range of environments. And if we might give her a microphone up here at any of these tables, if you have any response to the growth of iatrogenic fistula in the setting of hysterectomy.
Certainly. Nazmul and I work together in the same global project funded by USAID. And it's interesting, Bangladesh is an outlier in terms of what's causing iatrogenic fistula. We're seeing an alarming rise in iatrogenic fistula everywhere because we have a complete separation in cesarean capacity building and quality of care. And we talked about this last night. But when you separate capacity building from quality of care, you end up with a nightmare. So Nasmul just returned from a big regional meeting in West Africa representing the project. And in West Africa, it is primarily from cesarean section. And we're seeing this problem with too little too late if you're poor, and too much too soon if you're rich, across the board. But in Bangladesh, it's very odd. It's not so much from cesarean. We are seeing some from cesarean, but it's mostly from hysterectomy. What's interesting is that these hysterectomies are being done on very young women. The situation for women in Bangladesh is that they're still having their children very young, but I think the average fertility rate is around 2. So they finish their childbearing in their 20s very often, not uncommon, and they choose tubal ligation most commonly as a form of contraception. So in this young population, if they have any sort of problem, they're often, it appears that they're often, and I'll ask Nasmul to correct me, but they're often misled as to whether or not they have a problem. They're called into sonographic screening clinics to make sure that they're okay, and then they're told that they have a tumor and that they need a hysterectomy. They undergo this hysterectomy, and they often don't know that they'll never be able to get pregnant again. Some of them have not finished having their children or not had any children at all. And so there's some sort of phenomenon in the medical community in Bangladesh where this completely unethical gynecologic practice is allowed to perpetuate.
How does it result, how does it result in fistula as opposed to the mechanism of a baby who's obstructed and bearing down on the perineal space? So help us less gynecologically trained folks understand what's happening.
It's not obstetric gynecologists doing the surgery. It's minimally trained surgical people of some ilk or another. I can't call them clinicians. I refuse to call them providers. So I'm not. It's interesting in that region that it doesn't take a lot to declare yourself a doctor and a surgeon, even if you've never gone to medical school. Okay. I still find every time I repeat this story, I have to pinch myself and make sure I'm not making it up because it sounds so far-fetched, but it's happening. And for the most part, these young women are undergoing these hysterectomies by people who've never been properly trained at all, not gone to medical school, have not gone to medical officer training. And that's an entirely separate issue about standards at minimum and major legal challenges.
Thank you. Anything else people want to add around the panel?
It just seems like, Walt, we all know that the amount of resources that Walt has is very limited, but in other areas, WHO has been super successful at getting messages out, and I think cesarean seems like a perfect opportunity for mobilizing the women and maternal health communities. Maybe that happens on a small level, but it hasn't really been a WHO push that gets through all the regions and so that everybody knows about it. And that's just one small opportunity.
I'll just finalize by saying that the major opportunity this year is the International FIGO meeting, the International Federation of Obstetrician Gynecologists, which only occurs once every 3 years. And this year, a major theme, including with a panel that Ariadne Labs is running there, is on this theme of C-section maldistribution.
Hi, it's Pierre Theodore from Johnson & Johnson Innovation. Just to really draw attention to something that Laura mentioned, there's an interesting, if you will, tension between this idea of access and quality. And maybe, Adrian, I can direct this question to you. When we're often faced with workforce shortages, necessarily we think about task shifting and expanding the personnel that are able to deliver care, which I think does put at risk some of the important criteria that you mentioned around quality care delivery. Can you just comment a little bit on how to balance high quality care, but also making sure that we address workforce shortages?
For those of us who were at the session last night, I think it was very nicely stated by Edna. You know, I don't just want somebody who can give ketamine. I want a real anesthesiologist. And I think the same applies on the surgical side. And I think we do need to make a strong case to governments that what is needed is appropriately trained providers, not just any old provider. And what I don't think we have on the surgical side, and I may be totally wrong here, is the equivalent of kind of a standards document that says here are perhaps some of the skill sets, some of the basic principles. Maybe it's not quite so easy to create such a document on the surgical side. And I do want to emphasize the appropriateness from the economic aspect. And John and I have been working on some wordsmithing so that when we make an economic argument for surgery, we're not making an economic argument for somebody to make a lot of money out of exploiting patients. And that is a big loophole, in my opinion, reading some of what's been written out there about the economic arguments. But I think we need to be very strong in, we're not just talking about task shifting or task sharing to anybody. It needs to be people who can actually meet these standards. We've set the standards on the anesthesia side. I think the ball's in the surgical court to set similar set of standards.
Go ahead.
Yes, thank you, Walt. I think your question is a very important one on several levels. And while we can work on creating standards and checklists on what a person can or cannot do, how do you communicate that to the population in general? So if I'm living in a rural population and Dr. X is been taught, or person X has been taught to do a C-section, how do I know that they can do a C-section and not a hysterectomy? What's the because I look at them as a surgeon, and I don't understand that there's a bunch of people who have tiered this, that this is what this level of surgeon can do, and this is what the next level of surgeon should be doing. You know, at what point do you refer? So I would assume that that system inherently would need to depend on the ethical values, or you know, you can emphasize on it during the training process, that that is what the surgeon needs to know that he can and cannot do. But my fear is that in a rural setting, these are the people who will become the super quacks. They are the ones who are trained to do a C-section, so we've authorized them to cross that line that, you know, this clinical officer can give anesthesia. But how do you communicate to the population that this is not where you go when you want neonatal anesthesia? You know, this is an ASA 3, don't go to this chap, you need to go to a tertiary care center. So how to balance that out is a very tough area to work in. I don't have an answer to that.
Pierre, thanks for that question. I just wanted to add two things. One, the economic aspect of it's to people's providers' economic advantage to do C-sections. UNFPA for I think 3 years had a program which was well thought out, they thought, to train midwives in remote places to do C-sections, so they would be able to do the C-section if they had a woman in obstructed labor. After 3 years, the midwives were no longer midwives. They did no midwifery at all. There was no prenatal care, there was no antenatal care. Every patient that came to them got a C-section, and all they did was C-sections. They had to stop the program because it had been twisted completely by the unintended consequence of economic advantage. Somehow we need to address that. The second issue is not only is it training, but it's building up the entire, what some people refer to as the surgical ecosystem, or the whole service delivery platform. Some of the iatrogenic fistulas are simply because the electricity goes off and you're trying to close a C-section wound with no light and no suction. And I mean, things are getting sewed up and nicked that they don't expect. So it's a really good reason to emphasize the entire surgical obstetric anesthesia service delivery platform that needs to be built up in those areas.
Sarah.
This is going to sound like a plot, so I just want to
Turn yours back on.
Okay. This will sound like a plant of a question, and it's not, so I wanted to emphasize that, but it is kind of an opportunity to take advantage of a really expert captive panel with sort of so many decades of global surgery and anesthesia experience to ask, when it comes to the Surgical Equity Prize, and my mind is kind of buzzing with like still the kind of potential of it, like what would you want to see? Like from as your minds have been ticking over it, do you have any ideas or any kind of like a wish list, or I mean, I'd love to know what are the craziest images in your mind about the prize.
Well, first of all, decades of experience. You must be referring to other people.
I think you have the whitest hair among us.
Thanks. I have pages and pages of lists of things that I think would be fantastic for prizes, from the things I talked about, from maternal health and children's surgery, and I don't know, where do you start? Like last night, just getting oxygen and getting trained anesthesia providers, and I mean, this is I mean, young people in this room without decades of experience, this is something that their career can be based on for their entire life, and they won't be finished as well. So that's a very, very huge list. Each person will have their bias of what they like. You know, as a father, I'm really interested in children's surgery. As a neurosurgeon, I'm interested in neurosurgical procedures and the huge number of strokes that are the majority which are in low-income countries, and the huge numbers of traumatic brain injury that's the number 1 or 2 lethal injury in every country of this world. Those are huge issues. But each one of us will have our biases and favorite things of what we want to do, but there is unlimited things that we could. You need a lot of prizes.
I'll put in my 2 cents unless someone.
I think for me it would be very important to know that the solutions that are being looked at are applicable across a wider context. I feel that the global surgery arena to date has been dominated by the African experience. There has been a lot of surgical initiatives in the African continent, in the African context. And again, as I said recently somewhere, Asia is a kind of biggish area of the world, which is very different. And I think it was great to be given an opportunity to talk earlier today. And the Bangladesh experience shows really how different that area is. So I think the solutions that are sought need to keep in mind that problems in Brazil may be very different from those in Bangladesh, very different from those in Ghana. And similarly, the solutions need to be very nuanced. I think of an intentional effort to make this truly global in its scope would be very useful.
I'll add my 2 cents on has the simple potential, and it's leverageable, though it's still challenging. Solutions in measurement, I think, would be fundamentally important. And the key area to me is that we have some modest mechanisms for measuring what the quality of care in the public sector is, but we have none in the private sector. And the growth that I see everywhere, Asia, Sub-Saharan Africa, Latin America, is that because of the incapacity of the public sector to provide adequate access to care, that the growth that occurs is in the private sector, and it's often basic public insurance schemes that allows those to expand, like the RSBY program in India and for other versions that are expanding elsewhere. But the quality, and Laura Frenzy and Atul were describing exactly what's happening in some of those private sector settings, is invisible. And I think some of the most powerful and necessary tools are the measurement tools to understand what is the quality of care, whether it's just simply who's gotten care and what are the death rates and the major complication rates. That basic tool for governments to be able to oversee their own public health are going to be absolutely crucial. I think the really challenging tools that are also the major area is might be a kind of more ambitious prize in the long run, less within reach, are how to provide training systems for both the management level as well as the technical skills level of the providers, because many of these settings can't get their basic antiseptic practices, sterilization and cleaning to happen, the management of the anesthetist, the surgeon, the nursing to come together and manage as a successful team, avoid the inappropriate care, and so on. To solve those inappropriateness problems, you need a management. And the lack of management skills and ability to train people in how to have the basic understanding of, you have 2 operating rooms, you're trying to utilize that resource effectively, use it for appropriate care, not inappropriate care, tie it to the local need of the community. Those are training and skill capacity and coaching that needs to be provided along the way. I could imagine a prize in that area, but that is more ambitious. I can see a measurement prize is within reach, and then that training capability could have enormous leverage going beyond that. Some suggestions from the audience. Oh, I see some suggestions from the audience, and then we'll go for a last topic. So people who have other suggestions to add to the prize.
Well, I put it on. Okay. I'm Jannicke Mellin Olsen, President-elect of the World Federation of Societies of Anesthesiologists. And the most challenging thing, in my opinion, is workforce. How to recruit people, how to find all those people. We know that just for anesthesiologists to have a bare minimum, we will need 136,000 physician anesthesia providers today just to get a bare minimum. Where are you going to take all those people from? Well, you can say task shifting, task sharing, and so on. But we know nurses are in shortage as well, as are all others. How are we going to recruit all those people we need for our workforce? We need to start with reading and teaching, you know, from basic levels. But that is our greatest challenge, to get those people. And so the one who can come up with a solution to solve the workforce issue really deserves a prize.
Annette Hollin, I'm the Chair of External Affairs for the College of Surgeons in Australia. I think the way forward has got to involve engaging more women. I think there's a greater proportion of women sitting back here than there is sitting on the panel, and I think that is reflected in our hospitals and how that's managed as well. The greatest proportion of people providing healthcare is in fact women, and I don't know that we're engaging them in our development projects. And I think they'll be the important ones in management. I think never was teamwork more important than in an operating theatre, and it always involves our peri-op nurses, and most of them are women, and I think we're leaving them behind. And I think we need to engage those peri-op nurses, and I think we need to engage the women in our communities, but particularly the women in communities, not just the men in power in those communities.
In trying to address this, what is actually a frightening experience of what's happening in the private sector and the risk to the reputation of surgery and anaesthesia generally, in Australia, we have tackled this really by regulation. In other words, the private hospitals are expected to report on the same quality indicators as the public hospital, and that's been relatively slow in coming. But I just don't see any other solution other than regulation for private hospitals, that if you want to provide surgical anesthesia services, we need governments to say you need to conform to certain standards, and it's a question of how to get government to overcome vested interests and actually do that. And I don't know how one would do that in some countries. It's probably going to be different for every country, but surely that has to be the way to go, that we need to be asking governments to regulate the private sector in terms of safety and quality in the same way as the public.
Adrian, you had something you wanted to add, and then John will have the last comment.
Well, I was going to say, we actually put an incentive into the standards document for industry. So we've created our own kind of prize, if you will, that has no money associated with it. So currently, capnography to verify intubation, continuous measurement of CO2, is only recommended at the district hospital level. We've stated in there that when industry produces a cheap and robust capnogram, it will default automatically to becoming mandatory at a global level. So we've put an incentive in there that is not financially a reward, but it is a reward for a company who can do that because they'll have an instantaneous global market.
John Mira from Boston. Adrian, I have a question for you. Very impressed with the WFSA workforce data collection. Is that something that you're going to be able to replicate? And the reason I ask that is that the World Bank has made it very clear that they're going to remove our indicators if we don't continue to replenish them. So A, can you do this again? B, how can we help our surgery and anesthesia colleagues do the same thing so that we have workforce data that's coming through at least every 2 years?
I've made Emmy Suzuki a personal promise. We will provide data every 2 years. The WFSA, Jannike's the lead on that workforce data, is committed to making this a living, ongoing document. So yes, we commit. But I agree with you, we should be doing this conjointly so that we're putting the surgery and anesthesia data together.
So do you have analogs in those other communities that you can reach out to and gently coerce to?
We're negotiating with Mr. Putin for some bots.
Thank you to everybody for all of your work on behalf of global surgery and anesthesia and making them a part of universal health coverage. Thank you for making these subjects come alive for everybody. The questions help make clear how real this is and what the dimensions are.
For me, to perform a surgery, and I know I don't have monitoring, I probably don't have oxygen, or I know power will be cut off for an entire hour, it's very depressing.
We lose one female in this world every 2 hours because of pregnancy-related complications. We have 200,000 people in Kenya walking with cataracts, 100,000 of which could be operated with a 15-minute operation by a clinical officer.
Preventing infection, treating infection is a huge thing, not only in a country like India, but also all over the world. Out of the top 5 conditions which result in revision surgery or repeat surgery, #1 condition is infection.
If a lady had a prolonged labor, which is longer than the usual, they usually get a cesarean section in the developed world. But in Africa, they might not get, and they just die just because of simple things that we can do.
Innovation need not be very complicated or very technology heavy. It can be as simple as training somebody to do the right thing and making him do it repeatedly with motivation. And along the way, if you have simple tools which can help you, then you can add that.
It's time now. It was a time before, and we need to change that.
My situation was an acute abdomen from a little umbilical hernia, which got kind of trapped. And so the pain kept increasing. And like I said, when I got to a point where I couldn't think for myself, luckily enough, I communicated with my colleagues. Once you get to the hospital, you start having all those questions. Is it going to be safe? Am I going to go through? Am I going to wake up? Because I have had situations where patients never woke up.
There's a famous author that says that in all this surgical equities, surgery is the youngest brother of this whole universal health coverage issue, but anesthesia is the invisible brother. So safe surgery depends on safe anesthesia. You can't divorce them.
I was the privileged one cutting up people and trying to fix them. This time around, I was on the other side and went through the problems that they face, the waiting time, the lack of pain medication, the lack of safety in theater, the lack of family support by your bedside when you're alone, because you can die.
People have started to realize that surgery is now as much a part of public health, part of primary health care, in a way that we have never realized that before. And so now is the time to actually be able to have political will, as well as individuals, population themselves, realizing that, yes, not just about getting my vaccination for children, but I also need to have my surgery. When my son gets an appendicitis, he should have a surgeon that's able to do it.
We have the tools right now, all the tools that we need to actually deliver this service.
Collaborating across continents is going to be a life-saving maneuver for the patients that we take care of and deal with, for sure.
I think the time couldn't have been better for surgery.
It's a new area for the Challenge Prize, so that's giving us hope.